I would like to invite Dr. Kalayarasan as the moderator for the discussion on the dais. Dr. Kalayarasan is an energetic academician, currently working as an associate professor in the Department of Surgical Gastroenterology in JIPMER, Pondicherry.
We are going to discuss on a topic, probably actually for the surgeons it is something which is not familiar. Frankly speaking, for the first time, I have to really read a lot and prepare for a panel discussion, because most of the times we talk from our experience, but this is something which is most of the things we are not familiar. So that's why we have expert panelists with a combination of both surgical oncology, gastroenterologists, and also a medical gastroenterologist. So it's my privilege to invite my panelists, Dr. Matthew Philip, who I think all are familiar, who just gave a wonderful lecture, Dr. Rohin Mittal from CMC Vellore, Dr. Nizamuddin from Malabar Cancer Center, surgical oncologist, Dr. Arun Kumar, surgical gastroenterologist from Gokulam Research Center, and Dr. Fahim Abdullah, surgical oncologist from Aster. So what we'll be doing is we'll actually we have some 4 or 5 cases. So we will discuss the various aspects of the polyps using those case discussion. On the first case, we will look into all this classification and how to make a sense of when you see a polyp. So I think that's most important. So once we understand that, then the remaining discussion becomes easier. So that's how we have structured this session. Okay. So this is a 52-year-old male who underwent a screening colonoscopy and was incidentally detected to have these polyps. So these are the findings. So once you see a polyp, so what you should do, whether you just observe or you do a biopsy or you have to do a resection. I think that's the first thing which we need to decide. And so how we decide that? Because the reason why we should understand is sometimes patients come to us with a colonoscopy finding and you see a polyp. So you need to advise the patient. So what, whether it should be observation or has to undergo biopsy or resection. So maybe to start off the discussion, I'll ask Dr. Matthew Philip to, so in his experience, so when you see a polyp, how will you decide about this?
Thank you. I think, as I've discussed earlier, when we do a colonoscopy and we have two ways we will be doing colonoscopy. One is that we know that there's a lesion and then we do the colonoscopy for assessment or for therapy. Sometimes we combine it. Otherwise, when you do a colonoscopy and you come across polyps, generally polyps, when we see, we try to, if they are need resection, we resect. And we always almost resect it. And because of the technique of cold snaring, all the smaller polyps we just do a cold snaring, because without using a cautery, we just use a snare and just cut it. So, and then it will be sucked into a sump, and then that's for histopathology. But when there is for biopsy, generally it's not required unless you have got a high risk features. When you are saying it's an advanced polyp, which requires a definitive different type of treatment like EMR or ESD. So we need to discuss with the patient, we have to plan about them. And in those cases, we need a little more time to study about that. Generally in our unit, we always use narrowband imaging and we also use computer, AI mechanisms to enhance our adenoma detection rates. So in that case, characterization also easy for us immediately. And if it is generated up to 2A or 2B, we generally resect them at that time, if it is not large. Otherwise, genetic type 3, we always take biopsy. And in a pediculate polyp also, when we do a narrowband imaging and you find there is an abnormal or there is a sign of high-grade dysplasia or malignancy with biopsy. Otherwise, we generally resect all those medicines. So only those high-risk cases then we use. Sometimes we even use chromoendoscopy, suppose we are not able to see the flat lesions, margins are not seen, then we use chromoendoscopy also. But because of the advanced digital chromoendoscopy, now the use of true chromoendoscopy has drastically come down.
Okay. So to summarize, I think so we just observe when we know that the risk of malignancy is negligible or the malignant transformation is negligible in a polyp. So that's something which probably we don't do anything. And biopsy when is a high risk, which means there is a very high chance of is an invasive, a deep submucosal invasive cancer, which requires a surgical resection. So there you do a biopsy. And resection probably a kind of early tumors where endoscopic therapy itself might be curative, or when you have doubt, a complete resection might also allow you to do accurately stage. I think this decides what approach you use. Now we need some objective parameters.
Can I add something there? It's not that you just leave the polyp, don't do anything on the polyp. We actually tend to remove all the polyps, even if they're small, even diminutive polyps. But unless you are so sure a small polyp is a hyperplastic polyp, and even when you actually tell a polyp is hyperplastic, make sure that you are not missing serrated adenomas.
Yeah.
That is the biggest challenges we many times have. And the serrated adenomas we don't even see sometimes. If you see that there is some mucus or fecal matter sticking to an area, always wash and see. And there underneath there may be a serrated adenoma.
Okay. I think the point is because the first one observation in the current era, it's becoming much and much less. The role for just observation, because I think the point which we will be discussing further is because initially we thought hyperplastic polyps, they are benign, but now we know that there's a subset of hyperplastic with the serrated polyps, which have a high risk of malignant transformation. So which means that observation, that has negligible role in the current scenario. So it's between biopsy versus resection. Now to decide that, we need to objectively characterize, and that's where we have this classification. So probably the next 5 to 10 minutes, we'll just see about these classifications, and because the further discussion is based on this classification. So the first is the simpler classification is a Paris classification, which broadly divides into a polypoid versus non-polypoid. So polypoid means the lesion is elevated, which is more than 2.5 millimeters. And how you know that it is more than 2.5 millimeters? I think probably the biopsy forceps, you close it and you take it near to the lesion. So the closed biopsy forceps is 2.5 mm. And that will tell you whether it is a polypoid or non-polypoid. So it's more than 2.5 millimeter. And this is further subclassified as pedunculated, subpedunculated, or sessile, which means pedunculated we understand this as stalk, and subpedunculated, it is the stalk is not prominent as in the pedunculated, and then you have the sessile. So then you have the anything less than 2.5 millimeters, so they are considered non-polypoidal, which are further classified as flat elevation, mucosal change, and depressed. And then you have the frank ulcerator or excavator. Generally, this is more common in stomach. This classification is applicable both to stomach and also the colon. So that's something which is it's for throughout the GI tract. And this is not very common in colon, but more common in the stomach. So the practical application of this classification is, so as you move from 1P, which is the pedunculated polyp, and move towards this 2C, and then the 3, the risk of malignant transformation increases. So that's this is the simpler classification, and what is the clinical relevance of this classification. So maybe, so these are the ways you see the polyps. Maybe Dr. Matthew will say, once you see this, for the sake of can you just classify this based on the Paris classification?
And this is actually the first one is, that is very simple. We can say it's a pedunculated polyp, that's zone P. And that is the next one is actually subpedunculated, or it's could be even a sessile one. The below one is actually a true sessile one.
Yeah.
But I think, what we need to see that the polyp, when it becomes flat, and when there is any depression, then you should be very careful. Am I dealing with malignancy? Even if in a lesion, which is a large responding lesion, it's a multiple polypodal elevations are there. But if there is a area which is depressed, sometimes, even in an elevated lesion, we call it as valley side. When there is actually a depressed area, then it should be better. With the polyp which I have shown you on last, a small polyp, it had a valley side. The valley means just a depressed area. When you see a depressed area, then you should be very, very careful that am I dealing with malignancy or not. And I think, the treatment also varies. In the first one, we just do a polypectomy. The second one, you inject and do an EMR. The third one, since it is small, we can do EMR, or if it is not, you have to do ESD. But since it is small, we can do ESD. The first one is just polypectomy. Second one is inject and elevate and then cut. The second one is EMR or ESD. Because this is small, we can do EMR also.
Okay. So that's how you make sense of this Paris classification. But we know that the Paris classification is just based on a simple colonoscopy. Okay, you don't add any other additional features. But we know that just a simple observation and classification may not be appropriate. And that's why this classification was introduced, which is a nice classification, which is NBA International Consensus, colorectal endoscopy, which means that this requires NBA. So based on this, the polyps are classified into 3 types. So you look into the color, the vascular pattern, and the surface pattern. So the color which is same or light than the background, the polyp color compared to the surrounding mucosa. And the vessels, either you don't see any vessels, or the vascular pattern will be similar to the adjacent, the normal colonic mucosa. And you have the surface pattern, which is kind of either you see the white spots or there's a homogeneous absence of any pattern. So, which means this is more likely to be a hyperplastic polyp. And the type 2, where the color is slightly more darker compared to the background, and then you have the vessels surrounding these white structures, and the surface pattern, you have this branch white structure surrounded by the brown vessels. So this is more likely to be an adenoma. And then the type 3, where there is a marker distortion. So either you have the vascular pattern which is distorted, or some places you don't see vessels. So it becomes kind of irregular vascular pattern. And the surface also you have areas of distortion, or you don't have any specific pattern. So which means that's a deep submucosal invasive cancer. So again, now this probably tries to make it much more clearer of type 1, type 2, type 3, and this requires NBA. And this is what a nice classification. And again, probably, so once you, because this again you see like this, and maybe now you need to kind of decide what type of the polyps and the clinical relevance of.
I think, now we have moved from NICE to Janet classification, because
probably I think that we'll discuss next time.
So in the type 2, there are 2 subgroups.
Yes.
So that is important. The first one is actually straight away, if you see the pattern is similar to that of normal colon, or it is actually showing white dots, and in this type, it is hyperplastic. You can even resect it and leave it. But because of the fear of serrated adenoma, many times we send it for histopathology. The other 2 requires, other two requires intervention. The second one is endoscopically, and the third one, when the surface is lost. So surface pattern is not seen at all. It doesn't look like a colon.
Yes.
Because the surface looks so amorphous, pattern is not seen, the vessels are large, and it looks like irregular. In those cases, it is an invasive cancer. So the third one requires a biopsy and actually plan for further therapy. The second one you can actually choose, because at the same time you can inject and elevate and then cut it. So that is an adenomatous pattern. In this one it looks like an adenoma, and the pattern is irregular. How you identify it is that the mucosal pattern, the vessels are quite regular, and the surface Kudo pattern is well maintained, not like that normal. And the third one is it is lost. So that one is actually requires either an advanced endoscopy procedure or it requires surgical management, mostly surgical management.
So by looking at this most likely hyperplastic, most likely adenoma, and most likely a invasive cancer. But then we know that adenoma also there is subgroup with low-grade dysplasia, other with high-grade dysplasia. Now this classification does not address that. That's what the type 2 is not classified whether it is a low-grade dysplasia or a high-grade dysplasia. And that's where this JNET classification was introduced, which is a Japan NBA expert team classification. Now, Paris classification, just simple colonoscopy. NICE classification requires NBI. Now, JNET, in addition to NBI, you also require magnification. So that's additional criteria which is required, or the technique which has to be essential for further classifying. So the type 2 is basically subclassified as whether it is most likely it is a low-grade neoplasia or a high-grade, the low-grade dysplasia or a high-grade dysplasia. So that's the subclassification based on the surface pattern where it is regular. So you can see the vessels are much more regular, but here they become irregular. And here there is either some areas the vessels are very thick, some there are no vessels. So you can make out the difference between this, and you can subclassify as adenoma with low-grade dysplasia, adenoma with high-grade dysplasia, and the probably invasive cancer. So that's the third classification which you need to understand. And
yes. In this one, actually, the Paris classification says about the morphology only.
Yes.
It doesn't characterize. Actually, the characterization is with the NICE and JNET. And why characterization is important? Because we look at two things. One is the vessels and the surface pattern. And that can tell us whether there is high-grade dysplasia, low-grade or advanced or invasive malignancy. So that becomes, for example, in JNET type 2B, you can do a biopsy and look for malignancy, because many times it is high-grade dysplasia. And the other one, type 2A, I don't want a biopsy, I can just resect it. The other two, I think I should be careful about that. Because in type 2B, I should be either doing, if it is smaller one, I will be doing EMR or I will be doing ESD. The fourth one, type 3, should straight away go to surgeons unless there is a real indication for an endoscopic surgery.
Okay. And the last classification, which again we need to understand, is the Kudo classification. So this is based on the pit pattern. Now, this classification requires, in addition to whatever we discussed before, that is NBI, magnification endoscopy, also requires chromoendoscopy. So in chromoendoscopy, you use dyes or stains. Broadly, they are classified as absorptive and non-absorptive. The absorptive one is the methylene blue, where it is absorbed by the cells. And the non-absorptive, the typical is the indigo carmine, where it makes the pattern much more clear. So this classification requires chromoendoscopy. And based on the pit pattern, you can, so this is the normal crypts, you can see the size. And this is kind of the star shaped, the stellate, which is correlating with hyperplastic. Then you can see this is smaller than the normal, and this is tubular. So larger and tubular, this is smaller. So this is a 3S and 3L. So again, this more likely to be a high-grade dysplasia, tubular node high-grade dysplasia, whereas this is tubular node low-grade dysplasia. And here you can start seeing this there's a tubulovillous adenoma. And then you can see this, the pit pattern, as becomes malignant, it tends to become lost and more irregular. So this is based on the pit pattern, you classify the polyps. So in summary, when you see the polyp, you need to use all these gadgets and characterize the polyps properly so that you can decide what to do next.
Can I
Yes.
make a small comment on that? Actually, when you use a chromo, I don't recommend that everybody should do chromo endoscopy, because now digital chromo, the NBI, or depending upon the machine you used, actually they have got digital chromo endoscopy. But in chromo endoscopy, what I have, since I started early, I used to do a chromo endoscopy, and I had the fortune of visiting his, recently also I went to his university, Shawa University. Is a wonderful person. And what we have one for is, when you do a resection, you want to know the margins very clearly. Sometimes digital endoscopy will not show that. Then you have to use chromo endoscopy. Three things are used, as he told: methylene, then crystal violet. Crystal violet is taken by the cytoplasm, and methylene blue is taken by the nucleus. And indigo carmine is actually very commonly used for this one. So we generally use indigo carmine for this, because that will show the margin. Endocytoscopy, for you use crystal violet and methylene blue. And here also, when it advances like 5A, 5N, these all requires actually resection, and 5N is actually advanced, so surgery.
Yeah. So again, so probably you want to comment, like this is how you see that. So based on, you can see here, this is a typical of the hyperplastic polyp. This is a normal. And then as you go here, you can see becoming more advanced, like the invasive cancer. So this is how you, once you apply, so you will have this type of pictures, and you subclassify them and decide what to be done. I think we want to just focus on this, because traditionally, probably you must, maybe 10 years back, hyperplastic polyps, benign, nothing to be done. But now we have enough evidence to show that a significant number of hyperplastic polyps have this serrated pattern on histology. So this is actually a histological classification. There are some colonoscopy findings also to suggest that this could be serrated, but the definitive diagnosis based on histology. That's the reason why, as Dr. Matthew was mentioning, so most often when you see a polyp, we resect it and then we send it for histopathology. And this sessile or the serrated lesions have a higher incidence of malignancy compared to hyperplastic polyps, which have a very negligible malignant transformation. And if you see that, these lesions are more common on the right colon, and also the way they change to carcinoma. So typically you have the adenoma to carcinoma, whereas serrated polyps have a different pathway to become malignant. And in serrated polyp to carcinoma, you have this higher incidence of this MMR gene mutations, and whereas the APC gene mutation, which is common in adenoma carcinoma, is not seen here. So these are the important points which you need to keep in mind. And in fact, this is the reason why we no longer observe polyps. And it's important to understand this. This is the current classification for, because previously they are called as serrated polyps. And that term is not preferred because most often they are not polypoidal. That's why the term sessile serrated lesions is preferred compared to using the term serrated polyps, because often, as I told, the Paris classification, their elevation has to be more than 2.5 mm. Most of these, they don't have that type of a pattern. And this is what we just mentioned about the carcinogens are different. So keep that in mind. Hyperplastic polyps may not be totally benign, and you need to remember about this serrated polyp in the mind. And some of the technical aspects, so just because many, this is a good number of surgeons. So one is what you prefer to use for insufflation, so CO2 or air?
See, now it is mandatory that you use only carbon dioxide. In my unit, the central connection of carbon dioxide is connected to this one. Air I only use when I want to just past the throat. Sometimes you want a little more distension. Otherwise, air is not used at all. Carbon dioxide, because once you are doing advanced procedures, third space, you do POEM, you do ESD, you do colonoscopy. Even for colonoscopy, studies have shown using air and carbon dioxide, the patient satisfaction is much better with the carbon dioxide. Why? Because carbon dioxide is absorbed faster, and it is seen that the patients actually benefit by comfort-wise carbon dioxide. So I think it is better always to use carbon dioxide. There is no doubt. And preparation, I think it is really adequate. Without, if you are seeing some motion in the colon, never do a proper, you will not be able to do a proper colonoscopy if you are looking for polyps. You are 100% you are likely to miss sessile serrated adenomas, because it is always covered with mucin and motion. So you have to go for washing and all. So always we make sure that in our unit we also give something else. We actually ask them to drink simethicone and etc. So that actually the colon becomes all the mucin areas also will come down. And we also during colonoscopy actually we spray simethicone etc. to clean the mucin also. But basically what I think is that you should start preparing on the previous day and make sure that if it is doing for a colony polyp, and then make sure that the colon is completely clear, and then only you should. We have got nurses to look at the motion of the patient and come and say that it's not clear. They got a grading also. And unless it is clear, we'll never do that. We have a lot of fight with the patients also, because they have been preparing, and we tell that there is no, you give IV anesthesia, because most of the time we give IV propofol, because it takes a lot of time and for looking at a resecting polyp. And if it is not clear, it becomes difficult.
And one other important question which I want to ask is, because if you see the literature, whether you have done a proper colonoscopy or not, so these are the indicators, the adenoma detection rate and serrated polyp detection rate. But when I discussed some of the medical gastroenterologists, they told, they said that they don't use it because they don't see as many polyps in Indian patients compared to Western. So what's your opinion?
No, I think it's wrong. At least in Kerala, we see good. Now there is a good study going on in India, and regarding polyp, it is a multi-centric study. So many, I think 40, 50 centers are taking part. We are also a part of it. See, polyp detection rate is actually a very important thing. The best technique in what we can do is actually increase the withdrawal time. You can go to the cecum very fast, you go inside. But when you withdraw, minimum it should be 7 minutes, and preferably 9 minutes. Then your pickup rate will increase. So one is withdrawal time. And in our unit, we actually tell the sister, look at when the residents do, to ask to see that how much time they are taking for withdrawing. So it's very important. Or you can use new devices to look for that. The best is the CAD-I, that is a computer-aided detection of polyps. Adenoma detection is very high, but produces a lot of false alarm. Any bulge is actually shown as a yellow circle, yellow square. But that will give a prompt us to go and look at that area, there is any. So we look at that area, put a narrowband imaging. If there may be sometimes a small polyp, then you resect and come out. So I think this is very important. The purpose of doing this is much more important for Western countries, because there it is very common to have malignancy for screening colonoscopies. But I think it's also important for us to do that.
Oh, yes.
Regarding air and carbon dioxide, I don't know how relevant it is here, but apart from the flammability, as you are using
the energy source.
fire there, and the comfort of rapid absorption, it also is important when they embolize.
Yeah, that's very good.
Air embolism can
Yes.
be fatal.
Nitrogen,
Much less fatal. It also can be fatal, but if you oxygenate initially, patients.
True.
Especially when you do an invasive thing, when you cut the mucosa, then it becomes very important.
Because I think air is nitrogen, so which does not dissolve well, and that's one of the major issues. So regarding this, we have discussed this. I think partly Dr. Filmer mentioned about this. Although he also at the end mentioned that it's not really very critical, but the general principle is, when you feel that this is endoscopically resectable, ideally should not be biopsied. The reason is because once you biopsy, then that results in scarring and can make the future endoscopy resection technically challenging. But however, with the experience, probably it can be overcome. But this is a general principle. Whereas the
there is a
Yes.
problem, Why we take biopsy? The patient needs to be convinced. Suppose patients say, what is the evidence of cancer? Why you say it is high-grade dysplasia? Why you think it is resected by ESD and EMR and not something else? So we have to give an answer. So in those situations, generally we take at least 1 bite or 2 bites, not more than that. And preferably avoid the thinnest more area. But what I do is narrowband imaging, and the most likely area I take 1 bite. And you have to convince our pathologist. We say there is hardly any tissue. I told that is enough. You look at that and tell us what is there. See, that is very important. The pathologists require a lot of tissue. To convince the patient, you may have to do that.
Yeah. And the next point is about the tattooing. Same principles. For example, done by a gastroenterologist who does not routinely do this type of resections and wants to refer it to other center. With respect to tattooing, do you make any difference whether?
See, I think tattooing, some surgeons will fire us back, call us, what you have done, the whole peritoneum is black. We are not, see, so we are very careful about tattooing. And moreover, tattooing technique is also very important. What you have to do is, you actually, the site of lesion which you want to inject is away from the lesion, and you inject and actually inject saline and produce a blub in the mucosa, submucosa, and then you inject that. That then becomes, otherwise what happens, you inject, you will not see any blood. It actually would have gone to peritoneum because colony is very thin. The needle is around 5 millimeter or so. So I think it's that very careful. Now there is a new thing has come in Japan. It was a fluorescent one where you can actually in the theater you can look for that. Or what I use is I put clips so that the surgeons, or I ask surgeons, you can call us. We'll come and help you out in the theater. That's the commonest one now. Otherwise, tattooing is very good, but it has to be done very properly. Otherwise, it becomes a problem. The whole, I have got pictures sent by our surgeon saying what you have done. The whole peritoneum is black. It is also possible. It depends on when you are doing also. Suppose you do after many days, the whole area becomes black.
Okay.
India ink.
Okay. So I think that's the.
I think now you have to ask.
That's how I was about to tell. So now the first case is basically set the tone to understand about the polyps and some of the principles in management. And now we have expert surgeons, surgical oncologists, and gastroenterologists. So let's focus on some of the cases. And I invite, because more than one option, treatment option is possible in these cases, and invite comments from all the participants also. So this is a female patient, female patient who had a known case of ulcerative colitis on treatment, then went into remission. And after that, she lost to follow-up. She was on remission 5 years, and she lost to follow-up, and also she was not taking those medications. And then she presented recently with increased frequency, bleeding, and also occasionally she also had the obstructive symptoms, pain, and weight loss. So this is a presentation in a known patient with ulcerative colitis. And this is the finding on a colonoscopy. So she had obstructive symptoms, and when the moment you place it, so this is roughly around starting from 4 centimeters. So you have this type of polypoidal lesions. And so when you see this so before I go to the surgeons about the further management, so when you see this type of large polyps and characterization of this type of polyps on colonoscopy, so how accurate in this type of giant polyps?
It's a very, 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 very good question. Because in ulcerative colitis, the mucosa is inflamed. And we have got a situation of getting inflammatory polyps. And sometimes, we even get like these, giant pseudopolyps, giant pseudopolyps. We had to operate on patient, actually huge giant pseudopolyps. But here, I think in characterization using NBI may not be that wonderful. And studies have shown that in ulcerative colitis, if you want to look for dysplasia, chromoendoscopy is better. But now it has changed. Now people think digital chromoendoscopy and chromoendoscopy are both the same. But here, biopsy is a decisive factor in that. And this is a polypoidal lesion. It's a very big polyp and almost getting occluded in the lumen. And then I think biopsy becomes mandatory. Just don't rely only on chromoendoscopy.
So you do a biopsy. Yes.
And also background inflammation is very important. Here I take more biopsies because because I'm not seeing a proper area where there is a characterization can be done. So I think I won't take a resection biopsy, but I take deeper biopsy in this patient because I need to have a diagnosis here.
Okay. Maybe I'll.
And also, of course, I take biopsy from the surrounding. I mean, I will do a colonoscopy and then do segmental biopsy also to see the activity of the.
So you attempt any time resection when you see such type of.
No, these type of lesions, no. But if it is the general concept of dysplasia in ulcerative colitis, now it has slightly changed. If you have got multifocal dysplasia, surgery straight away. You have got a evident lesion in the colon with high-grade dysplasia. For example, a 3 centimeter lesion, then there is a possibility of doing actually endoscopy resection. Otherwise, no.
Okay. Maybe I'll ask, start with Dr. Rohin. So, for example, you have now, this patient is referred to you with the colonoscopy done outside. So, this is the picture. So, what will you do? The next steps. So, you will ask your, so they outside, they haven't done biopsy also. You have only the report showing this. So, you will get the biopsy, or you don't even ask for biopsy, or you ask some other investigations. So what's your...
so the key question here is there's somebody with long-standing ulcerative colitis who's got now come back not taking medications and has got this giant lesion. The first question that you have to ask yourself is this cancer? Because this is very much possible, long-standing UC, not on medication. So that we have to rule out. Second question to ask is what is the length of involvement of UC at present? So we've got only one image here. We need to evaluate the whole colon. So what I would do is request a repeat endoscopy, request biopsy, see if this lesion is traversable and look at the whole colon and take multiple biopsies from throughout the colon to see what happens. And also parallelly, I would request imaging to see what the depth of invasion is, or is there a solid lesion, or if there are nodes associated with it. Primarily aiming to rule out two things: cancer and length of colonic involvement.
Yeah. So probably now the decision making is, as rightly mentioned, so about this polyp and also the disease in the rest of the colon. Now we have taken multiple biopsies. It came as tubular adenoma with high-grade dysplasia. So next, anyone else? I think.
Just a comment, like MRI pelvis, abdomen including complete liver, HRCT chest, and a CEA.
Okay. So this is the MRI pelvis. I know that it's a short time to make a but what's your view after seeing this MRI in this patient? So I will tell the provisional report is.
It's showing invasive component.
Yes. So there is an invasive component T2. T2 is the MRI staging of this lesion. Now, you have a large polyp, and possibly it's invasive, although the biopsy now shown adenoma with high-grade dysplasia, but based on MR, it's more likely at least to be a T2. That's based on the MRI. Okay. Now, in this scenario, what will be your next line of management? No other, the CT abdomen is normal, and there is the colonoscopy showed some inflammation up to sigmoid colon. Okay, beyond that it is normal mucosa. And I'll also, once I get the opinion from the panelists, I also take opinion.
You should ask the audience. See, if you ask me, I'm not very happy to do endotherapy in this patient. One of it's a large lesion, it is circumferential, and also with ulcerative colitis. I have a strong feeling that this person have biopsies maybe not representative. The person may be harboring a adenocarcinoma in this patient. And this patient, a drug falter, very unlikely that the patient will continue treatment also, even if I resect. And this resection is because it's circumferential also, it can even produce stricture there. So I am very skeptical about doing an endotherapy, but that will be my last choice. Young person, a defaulter for a poor compliant patient, and I think, if he can go for surgery, that would be better. But for that, I need evidence, because there's some evidence of malignancy or significant dysplasia. If this should not be just a polyposis, it's pseudopolyps. It should be, because there is definitely an adenoma.
Yeah.
And having said that, in persons with ulcerative colitis, if there is actually a lesion, adenomatous lesion, if it is a pedunculated polyp, we actually treat it as a conventional polyp. If it is a dysplastic lesion secondary to ulcerative colitis as a flat lesion, we actually give a choice of surgery versus endotherapy. Now, organ preservation is important. And if it is, as I told you, multifocal dysplasia, because you take biopsy for right colon show dysplasia, left colon, more than one area if it is dysplasia, and if you are not sure where it is, then in those cases, actually visible lesions are not there, surgery straight away. If visible lesion is only one, it is amenable to endotherapy, we can do. But pedunculated polyp occurring in ulcerative colitis and a conventional patient is almost treated as same.
Okay. So PR, there is a friable growth starting from 4 centimeter from the anal verge.
So in this situation, I guess the endoscopic ultrasound would not add too much more information, considering the volume of the disease.
No, it can, but maybe we can actually look at and tell that, but that will not actually change. It is, even if it is a T1 lesion, it's a malignancy, and this patient has an underlying ulcerative colitis. In a conventional patient, I would have definitely gone and looked for endotherapy. But here, being underlying disease is ulcerative colitis. We're looking all the background. I think we should be more pro for surgery, unless there is a real evidence not to do surgery, then I'll do the endoscopy.
So I think right now the consensus is no role for any endoscopic therapy in this patient, and so we are talking about surgery. Now, question I want to ask is, we have seen this is a bulky lesion. Now it comes as adenoma, so it is not a inflammatory pseudopolyp. In this type of lesion, so what is the role of now neoadjuvant therapy? You want to directly operate, or you want to consider neoadjuvant therapy? Now, the biopsy is only tubular adenoma with high-grade dysplasia. The MRI staging is T2, but it's a bulky lesion. We have seen that it's fully expanded, and so you will directly go with surgery, or you consider any neoadjuvant therapy in this patient?
I think we should go for a direct surgery, because there's no real proof to start neoadjuvant therapy in this patient. And most radiation oncologists will not be willing to give also.
No, what I'm asking is whether you want to do a repeat biopsy or want to prove whether there is any invasive component after the MRI.
By doing a radiation, what are we going to achieve? So here, we have no answer versus cancer, but we know that generally in some places high-grade dysplasia is being considered as carcinoma in situ or a intramucosal carcinoma. So that is different. Otherwise, by giving radiation, what are we going to achieve? Because here, in that case, if the surgeon says, I want a proof, then I'll go for a resection. Or I will take a big chunk of tissue. I do a polypectomy type of thing. Then actually I get a bigger tissue, and that shows the lesion is there or not. Here actually maybe I can do what I'll do a repeat biopsy, a deeper biopsy, and I'll represent all the areas for biopsy. Then I think the yield will become better.
So one of the challenges is, maybe Dr. Deepak might remember about this patient. So it's a bulky lesion. Now it's 4 centimeter. It's about whether you want to reduce the bulk by giving that is the only question, because achieving the margin and able to completely do a RZO resection. Maybe I think Dr. Ayyappan wants to add something.
That's what I just want to know. What is the actuality for putting this question? There should have been something
Yes.
you are asking for. Was that because we saw some nodes and other things? The nodes are well away from that of your mesorectal
Yes.
fascia. But if on the MRI, if you have found some nodes which are very close, and if you are suspecting that you're not able to get CRM. Then you can think about some neoadjuvant and then you go ahead.
Okay.
But
See,
whatever we saw was only about 8 seconds of your
Yes, yes.
video. So are you hiding something or are you wanting to
No.
bring out something?
See, Professor, Dr. Ayyappan and Dr. Anderson, now, see, there is something called real evidence on tissue and your experience also. Sometimes your mind says it is not this. My mind says this patient should go for surgery because I have a strong feeling he may be having adenocarcinoma. So if you want proof, then we have to take more that tissue. Otherwise, we cannot say.
Sir, as of now, the discussion is in rectal cancers, we are moving towards that of unimodality of management.
Yeah.
Here, that's what he is trying to bring out.
Yeah,
So
I agree.
we also want to take it to that line. But
No, for that we need a tissue. We need a tissue, no?
we are talking about taking the bulk. If the CR
Yeah.
is going to be comfortable, take the bulk without disturbing the MRM, take it out and give it to the pathologist, get a proper reporting, and then go ahead with the further management.
The key here is it
If the biopsy was an invasive cancer, would you go for pre-operative?
that is, I think, the most important question.
MRI.
So the question here is, this is T2. If you look at the MRI, whether it is high-grade dysplasia, whether it is T1 or whether it is T2, your treatment is the same. It is surgical resection.
Yeah.
If there is doubt on the MRI that this may be beyond T2 or the CRM is involved, at that point, you will have to think, I need to prove my diagnosis before I give chemotherapy
Yeah,
or radiotherapy. And for that, it's very, very difficult. Sometimes you will take 2 biopsies, you will take 3 biopsies, you will go EUA, we will do a transrenal excision. Sometimes you just won't get it. And so there you are stuck. And there you have to take an active decision in an MDT saying, okay, this on the MRI looks very much like malignancy. We will go ahead and give some treatment without biopsy. Or you go ahead and say, we will give this treatment and give adjuvant therapy. That is a real problem. Because you can take 3 biopsies, 4 biopsies, and you won't get an answer.
So the main reason for bringing out that neoadjuvant is because the bulk. The bulk was concerning in this such a bulky lesion to go beyond that and getting the margin. So whether neoadjuvant will reduce the bulk. So that was a thought process. So I think as Dr. Deepak mentioned, if biopsy comes invasive, where that issue of starting neoadjuvant is not a major problem. So whether anyone will consider neoadjuvant will reduce the bulk or everyone feels that direct surgery.
Kalayarasan,
Yes.
bulk is not a criteria either, I think. MRI picture which shows
Yes.
T2
Yes.
and beyond T2, Dr. Rohin was mentioning, even beyond T2, for a T3A or T3B MRI disease, neoadjuvant radiation therapy is not a uniform recommendation now.
Okay. Fine. I think that's point well taken. So that is.
One more thing, I strongly believe sometimes, MRI overstages diseases, and early stage.
Yes.
So in this case, I think we just should not go criteria only T2. The lymph nodes are very important. So I was wondering, is there any way we can actually do some other investigations to look for the lymph nodes?
So again, just to bring up that point, I think we overemphasize on lymph nodes sometimes. There is more importance if you see tumor deposits, if you see EMVI, just presence of lymph nodes in the MRI actually is not of great prognostic importance. That has been shown in Western data and our data as well. So I think we have to be very careful because very often we get carried away by saying, okay, this is T2, but there's a lymph node, so therefore this needs to go for neoadjuvant therapy. But the importance should be placed more on other high-risk factors.
Lymph node could be reactive or
it could be reactive, yes, sometimes they're just there. And the prognostic significance...
Does PET scan do some benefit on this?
I don't think so. There's no role for PET scan in this case because we are only going to get confused. So I think the decision has to be clinical. And this is ulcerative colitis, even if it's high-grade dysplasia, the whole colon needs to come out.
Okay. I think we had a good discussion on this case. So that's all the points. So finally we did, I think as everyone suggested, direct surgery and total proctocolectomy. So can we have the, okay, the image is not there. So the challenge was mainly with respect to bulk. So because going beyond that and having a margin, but finally the patient we could achieve and no, single stage. So, no, I mean 2 stage with a covering stoma.
While the slides getting
Yes.
see, in that aspect we can differ a little bit. Like I would see a T2 lesion on MRI with high index of suspicion of malignancy. We don't know the actual pathological states. 2 options. One, as you said, your side. Second, do an endoleostomy, wait for the histopathology report, just see the T status, N status, and then decide the closure later, something like a pouch later.
No, there again a issue. Doing a pouch later after doing such a low resection is going to be technically challenging. Maybe again I can ask opinion because you do something like ISI in this patient and then doing a pouch later.
One thing. Initially, the Sir Matthews had told that scopy was normal. Proximal thing was
Yes.
just for my own
Yes,
knowledge.
yes,
Why did you take out the whole column? Is it because ulcerative colitis? you
yes,
took
yes. Ulcerative colitis.
So,
It's a known
out?
ulcer.
Not supposed to
See, Dr. Ayyappan, in ulcerative colitis, there is no restrictive surgery. It's actually total colectomy, whether it is left-sided or in Crohn's, of course, we have to be restrictive. In ulcerative colitis, I don't think any surgeon will agree or IBD specialist agree for a restricted assessment.
those, why?
The reason is that we know that even if you see a person with proctitis now, later he
What's
can
the time duration?
no, I tell you, later he can progress over a period of time. And I will tell you about a story of a person who came to us with a left-sided stricture, ulceration and bleeding. So in emergency, this patient was done a surgery somewhere and they did a left hemicolectomy. And this patient later came to us with extensive colitis of the leftover colon. So this is possible that IBD can occur in the leftover colon.
No, Kalan, I think
Yeah.
it's very common. I tell you, in surgery, you find a cancer, he's known to have ulcerative colitis for 10 years, and he knows total proctocolectomy. Either you can have either restorative or end. But the patient, so many of them will say, I only want a local resection. What can you do as a surgeon? You'll tell them the risk of cancer in the residual colon is there. But it's not uncommon that we do segmental resection despite advising them. So I think that's what Dr. Ayyappan is saying.
The quality of life following that of a total colectomy versus, that's all.
No, because I think the general teaching in ulcerative colitis is if you remove a segment, then the disease recur in the remaining portion of the colon.
Again, when
Yes.
you entered the podium, you told, I've learned a lot by this thing, man at this stage. So, we also want to learn something, so yeah.
So I think that's the reason why we don't do a conservative resection ulcerative colitis, because it is well proven that disease recurs in the normal appearing colon once you do the resection. Yes.
And the risk of cancer is there in the other colon as well, and there's a very high risk that you will get a second cancer. If patients do not follow up, then definitely they will have a second cancer. So the current standard recommendation is total colectomy. Yes, of course, on a case-by-case basis, you can say that we will not. It's similar to familial
Not put this picture.
No, Dr. Rohin, this is a young patient is a defaulter. She did not take medicine and having known that it's a lifelong disease. So in this patient, total colectomy may be a better option rather than.
It is the
Yeah.
recommended and it is the correct
And that is the correct one. I
Okay.
have never done that.
I think we'll go ahead because we are running short of. Yeah, please.
And just one more. So you did a pouch for this patient,
Yes, yes,
hopefully.
pouch.
So what are the extra dangers of doing a pouch and say the patient turns out to be like T3 or node positive and she needs adjuvant RT as well?
Yeah, that's always a risk because once you do a pouch, then giving radiation is going to be a challenge. So because we had now all the MRI staging which tells it is T2, so maximum we are expecting it to be a chemo, only chemo, so not radiotherapy. So that's the reason why a pouch was done there, because the problem is you just do only colectomy and stage pouch later, it's practically impossible to do a pouch later on. Yeah. So you need to take the decision based on all these factors, and probably it was felt this is.
Please say it is difficult.
Yeah. Okay.
Yes, I also want to say it is difficult. It is not. It's
No,
not
yeah. Okay, fine. And so this also, if you see the final staging is PT1 in this case. So this is again the point when there is an expansile growth or the polypoid in the rectum, MRI tend to overstage. So which has been also highlighted in the talk before. I think we are running short of time. Probably I'll just quickly go through this case. So we read about, had a discussion about the lateral spreading polyps. So the thing is here the spread is laterally more than 10 millimeters. So that's the criteria. Broadly the surface, whether it is granular or non-granular, that determines the risk of malignancy. So this is granular polyps which are less likely to be malignant compared to the non-granular polyps. Now this granular polyps itself can have, whether there is a nodularity, then the risk of malignancy is like this, then the risk of malignancy is slightly higher compared to the non-granular. Even otherwise, the risk of malignancy is more than the granular polyps. Now the lateral spreading polyps, once you determine the risk of malignancy, so you can decide about the therapy. This is, for example, this is lateral spreading tumors, granular types. You can even do a piecemeal, because the challenge here is they tend to spread much more wider area, and doing an en-bloc resection can have some technical challenges, although I think this is a case shared by Dr. Matthew Philly where they have successfully done one of the cases. But if it is this, where the risk of malignancy is low, you can even do a piecemeal EMR, whereas in non-granular types, you need to always aim for an en-bloc resection.
This is one area where chromoindos will help us to look at the margins.
Yes. And yeah.
While this video is going on, we can actually have discussions.
No, I think there's one more because I want to cover, because there was initially we were not planning to go because of a talk on transanal surgery, but that is not there. So we'll just quickly cover that aspect, and then with that we'll complete. Maybe we'll take another 6 minutes, okay? So this is a patient, is a 40-year-old male, present with bleeding and mass descending per rectum, 2 months duration. So biopsy, so this is the lesion. You had a polypoidal lesion around 7 centimeters from the anal verge. That's on perrectal. And so 7 or 6, okay. So this is, you can see, this is actually video taken by the patient. So the quality is not good. So while staining, you can see here the polyp, okay, it's not seen well in this. You can see in better. So it's actually the kind of, the polyp was coming out every time he strains while defecating. And so obviously you do this when the biopsy is adenocarcinoma, you need to do MRI pelvis. And this is the MRI of this patient. Again, let it play, but the MRI T staging is T2 in this case. And there are small nodes, I think 5 and 6 mm node. But the suspicion of metastasis is lesser in this patient, in the nodes. Now this is the staging, this is a presentation. What I want to ask is, so 7 centimeter lesion, MRI T2, N0. The line of management is direct surgery, or if it is direct surgery, anyone wants to consider a transanal surgery in this patient, or a direct LAR.
Can I please read that MRI?
Yeah, please. Okay. Yes, yes. It's good that.
No. I think this is a less than T1 pedunculated polyp, and the polyp attachment on the sagittal image that you showed is to the. On the sagittal image, you can see that the polyp attachment is to the posterior wall. So this is a T1 or less stage pedunculated polyp.
So I would say that actually this patient, for further data, this patient actually referred from elsewhere. This is what the report was T2N0. In fact, I mean, for the this patient received RT and then came back to us. So that, but I skipped that because there's no indication for neoadjuvant therapy, so I didn't include that in the discussion. But that's a point well taken. Okay, now it is T1 as per the MRI staging. So maybe now the question becomes more relevant. Any role for transanal surgery, or you will consider LAR?
We can consider transanal surgery.
So what is the indication? What are the conditions or situation where you consider a transanal surgery?
The lesion has to be well differentiated, and PNI and LVSA should be absent, and MRI wise and endo-ultrasound wise, it should not be more than SM1.
Okay.
So there are certain situations where we can consider a well differentiated lesion with SM2. SM2 means the middle third of submucosa is involved, but never a poorly differentiated or SM3 lesion will be considered for such a procedure.
Okay. So before I move further, I'll ask either Dr. Rohin or Fahim. There's a patient who underwent a neoadjuvant therapy. Okay, see a rectum, say same. For example, this patient came back to us after neogen therapy. Now there is a near complete clinical response, and on scopy, you just see some scarring in that area of lesion. Now, patient wants the organ preservation. In those patients, do you consider doing a transannal surgery, which means doing that area a full thickness resection, or you will just observe?
So it depends on a few things. One is, again, the initial histopathology and what it was, whether it should not be a signet ring pathology, mucinous pathology should be well differentiated. It also depends on what radiotherapy you've given, whether you've given long course or short course, and how long you've waited. Now, if it is 6 weeks post-response and you have a near complete response, you can wait longer. If it is 10 weeks, probably you can still wait for a few more weeks, provided that the patient is willing to come for regular follow-up. I know Guilherme probably is a better person to answer this question, but they also give chemotherapy to try and get complete response. So, Guilherme, your thoughts on this also after finish. But yes, if it's a near complete response, we can wait longer to get complete response. Second thing is, it is not standard to do a local excision, but now there is evidence coming from the TREC trial and the STAR-TREC trial, which have been running in the UK, that radiotherapy followed by local excision is a viable option, but it is not standard of care.
Okay. Yeah.
Yeah, but I completely agree with Rohin. When we suspect there is a huge component of benign disease in the lesion, we would not recommend radiotherapy with organ preservation intention. We would try perhaps a local excision, even if the MR says it's a T2, because usually they overestimate these lesions. And but apart from that, if there is a high suspicion of malignant disease, we would go with the long course chemoradiation with consolidation, and would give this patient a few weeks, perhaps 12 to 16, okay, and maybe do a local excision if the initial staging was that early tumor.
Okay, thank you. So the reason for asking this question is to bring out the indication for the transannal surgery. Yeah, Dr. Fahim, you want to add anything?
No, also, I think in the changing scenarios of total neoadjuvant therapy, we are giving more and more patients getting NACT also as well as radiation therapy. So we are getting a lot more complete responses. But as Dr. Rohin said, I don't think it should be considered as standard as of now. Oh. If a patient would otherwise end up with a permanent stoma and APR, may be considered as a wait and watch policy, or maybe at best experimental.
So we will have a very quick description of this because we didn't cover this. Now the transannal surgery, there are many options. One is, this is one other technique which Dr. Nizam will, quickly will finish off, okay? Yes, yeah. And then you can even use a silk port and then use a conventional laparoscopic instruments. Maybe we'll have a quick description and then we'll end with this. Yeah.
Yeah, this apparatus is TEO, transannal endoscopic operation, produced by Stores. So these are specific instruments for doing this procedure. So we can see the rectoscope, the videoscope, obturator. This is the table attachment. For fixing the apparatus to the table, patient is positioned, the rectoscope is placed into the rectum. And this entire assembly is attached to the table so that it doesn't move. It gives a stable platform. And you can see the working ports through which we introduce the instruments. So this is a reusable autoclavable instrument. We have disposable instruments as well. So this is the attachment. This is going to the table to provide a stable platform. So this is the lesion, intraluminal view. So what we do is we resect 1 centimeter around the lesion, and deeper margin of resection is mesorectal fat. So we resect along with the musculature of the rectum. This lesion is situated posteriorly on the rectal wall. So the patient has to be placed with the lesion down. So the lesion should be at 6 o'clock. So what you see is the mesorectal fat. So the curved instruments are really handy to do this procedure. And the cautery has a suction channel in it. So with the hand press, we can suck out the smoke also. Using a laparoscopy insufflator. And we keep the pressure around 16 millimeter mercury. Carbon dioxide, yes. Once we resect the lesion, usually the defect enlarges because of the carbon dioxide insufflation. No, I kept a gauze piece beyond that too.
Okay, to maintain the, so that the pneumo does not.
Yeah, it's convenient. It's not absolutely necessary, but it's helpful.
Okay.
So after the resection, we give a good wash. And I generally close the defect.
Yeah. So this is using this platform. You can also have this conventional laparoscopy instruments, use a silk sport, fix it. And so this is using the conventional, so you're using our usual laparoscopic instruments, the hook cautery and excises. So that's also one method.
You can do a conventional transnasal excision also for lesions which are situated distal to 5 centimeter. But what I usually do is I start conventionally with a metal retractor or the Lone Star retractor in the anus. I start distally. But once we start elevating, as we know, the margin goes deeper and deeper. Then I attach this metal platform. That is helpful.
Okay. Yeah, I think just for Dr. Anudam, this is the biopsy, final biopsy of that patient, which you mentioned. It's maybe T1. It came as carcinoma in situ, but the patient came to us after radiotherapy. So partly, I don't know whether the radiotherapy also had the influence, but definitely we also felt that this didn't look definitely kind of even a T2. So I think that's important. I mean, so many lessons. Polypoidal lesions, we have to be careful with staging in using MR. There's very high chance of overstaging, and all the points which we have discussed. So this is a summary, but I think we won't. We have discussed all these aspects in this panel discussion. Thank you. Thank you again, the panelists, for the participation.